everyone, welcome to my channel. In this video, we are going to learn about the CKD and the gout. So there is a bidirectional or two-way relationship between the CKD and the gout. Means CKD can lead to the gout and gout can lead to the CKD. So normally what happens is about two-thirds of the uric acid from the body is excreted through the kidney. What happens in CKD is the renal function declines. That means the GFR decreases drastically. Due to this, there is less filtered uric acid level from the body into the kidney, and also there is increased tubular reabsorption through the ureter channels and the renal tubules, and thus there is decreased uric acid secretion from the body, and thus leading net effect of increase in serum uric acid level. This increase in serum uric acid level, also known as the hyperuricemia, ultimately can lead to the gout. What happens is that this hyperuricemia ultimately leads to the crystal deposition in the joints and tissues, and leading to these are the monosodium urate crystals, leading to the gout or flare up in the gout, which is usually characterized by pain, redness, and swelling. Also, what happens is over time, when the patient has the gout, and the uric acid crystal deposition also occurs in the kidney, leading to inflammation, tubular injury, as well as the kidney stone formation, and ultimately causing acute urate nephropathy, kidney stones, as well as chronic interstitial nephritis. And with ongoing injury, there is further decline in GFR, and more hyperuricemia can occur, also further decreasing GFR, and thus there is a vicious cycle which causes the CKD to cause the gout, and gout to and further causing the progressing CKD. So how gout worsens the CKD? What happens is, I have already talked about, and when there is gout, there is uric and crystal deposition in joints, and also there is hyperuricemia. This hyperuricemia ultimately causes uric crystal deposition in the kidney renal tubules, causing inflammation and tubular injuries, which over time progresses to interstitial fibrosis and scarring, and over years, it can cause the decline in the GFR and further CKD progression. And other factors also contribute to this progression in the worsening of the CKD. These are hypertension, obesity, and metabolic syndromes, diabetic use, and acidosis, and oxidative stress. Also, the drugs used in the CKD, and usually the diuretics, can worsen the hyperuricemia by various mechanisms. Like these drugs usually competes with the uric acids and for the active secretion in the tubular lumen, and due to which the uric acid is not excreted actively, and its level is further builds up in the blood, and further increasing its level in the serum or the blood, causing hyperuricemia and ultimately the gout as well. So we have to screen uric acid in patients with CKD, and we have to treat hyperuricemia early to prevent the gout flare-ups and slow the CKD progression as well. So the takeaway is CKD reduces the uric acid excretion, causing the gout, and gout and urinary nephropathy further damages the kidney. So we have to break the cycle early so that we prevent our joints and kidneys from the damage. So how to manage gout in case of kidney? The real goal is to relieve the pain, relieve inflammation, prevent flare-ups, lower the urate level, and protect our kidney function. The first and foremost is the treatment of the gout acute flare. So we have to be very cautious, like in case of CKD patient, because we cannot use the typical drugs like NSAID, or it's better to avoid NSAIDs in case of patient of CKD. But in non-CKD patient, we first go with NSAID drugs. So it's better to decrease in case of CKD because it can worsen the kidney function, and it's better to avoid in case of eGFR less than 60. And our first line drug is usually colchicine, and we have to be very cautious and reduce the drug dose for the CKD in GFR less than 30. Also, and if this drug is not tolerated, or there is not improvement, or the GFR less than 30, we can have the other drug, that is alternative drug, is glucocorticoids. We have like oral glucocorticoids, and intra-articular steroid injection can also be done to treat both the gout flare-ups. And we have the second drug, that is urate lowering therapy. And what it is, we have to start it when there is tophi, or there is more than two flares in air, per air, or first flare with CKD stage more than or equal to stage 3, we say. Uh, our first line drug is the allopurinol, including in the CKD. What is known is we have to start low and go slow, and we have to titrate the drug every 2 to 5 weeks to reach the target urate level. And our target urate level is the less than 6 millimeter per deciliter. And if there is presence of tophi, then we have to keep the target less than 5 mg per deciliter. And if also we have to be very cautious, like its dose need to really need to be adjusted as per the renal function. And if it is not tolerated or it's not available, then we have the alternative drug, that is the febuxostat. Also it has to be started low and go slow. And to note, its dose does not need any adjustment for mild to moderate CKD. And we have to use it with caution in advanced CKD in patient with cardiovascular disease, as it increases the risk of the cardiovascular disease. And uricosuric drugs like probenecids are not very effective in case of gout and CKD. So other factors that we need to take into account while managing the gout and CKD are the lifestyle and the diet. Like adequate hydration is usually really important. So how much water to drink means the patient has to be instructed about either drink 2 to 3 liters per day, or until your urine is light yellow color or it is colorless, to that level they have to drink. And you have to really avoid over hydration as well, because it can lead to the fluid buildup in case of CKD patient. Another important goal is weight control. We have to usually encourage the patient to decrease the weight. And also regarding the diet, you have patients should be counseled about the limiting the purine-rich foods like red meat, organ meat, shellfish, and also to avoid alcohol, especially the beer, and also the limiting the fructose containing drinks as well. And also patients should be encouraged about low fat dairy foods, vegetables, whole grains, and vitamin C. And we have to do the monitoring of the patients like every 2 to 5 weeks until a target is achieved, and then every 6 to 12 months. And also the regular monitoring of the renal function with the serum creatinine, eGFR, is necessary. And also have to watch for the adverse effects like the rashes with allopurinol, liver function test, and cytopenias, and assess the patient adherence and the lifestyle factor. The general principle is we have to avoid the nephrotoxins like NSAIDs, contrast aminoglycosides to protect the kidney, adjust all drugs as per the EGFR, and treat comorbidities like hypertension, diabetes mellitus, and hyperlipidemia. And patient education about the adherence, diet, and hydration is a must. And we have to make the shared decision with the patient.
So the key takeaway is we have to use colchicine or steroids for flare-ups and avoiding NSAIDs.
Allopurinol is the first urate lowering therapy in CKD patient. We have to start low and try it to the target urate level. Lifestyle modification and regular monitoring are essential to reduce flare-ups and protect the kidney function. Thank you. Thank you for watching this video. We'll meet again in our next video. And if you understood some basic concepts, then like, share, and subscribe. Thank you.